Michael, great talking to you again. My best to your good wife, Jen. My colleagues in Harvard Med from the old days, Dr. McKaylee and Brian Fitzgerald. Michael, you're a doctor specialising in concussion in the Lyon McKaylee Medical Centre in Boston. You specialise in this field for a number of years now. Is that correct?
That's right. Yeah, I'm the director of the Sports Concussion Clinic at Boston Children's Hospital, and I'm a physician at the McKaylee Center for Sports Injury Prevention in Waltham.
And the initial, when you mentioned the concussion clinic, was that not one of the first set up in the world, 2006, I believe, with William Sheehan, was it? That's the first.
Bill Meehan, Bill Meehan's he is a co-director with me. He's been brilliant, and he's one of the leaders in the concussion research to this day. So he started out with us, and he established the concussion clinic, and we've grown it since then with him, and we're proud of it as it continues.
That's great. Just talking about concussion, and it's a word we talk about. We call it in the medical terminology TBI, or traumatic brain injury. That's the medical definition per se for concussion. Surely the fact that up to 90% make a good recovery in about 10 days, maybe a temporary brain injury, is more accurate in its description.
Well, perhaps. I think it's still TBI, traumatic brain injury, still gets to one of the hearts of the issue, which is that there needs to be some type of trauma, either direct or indirect. In the past, we've thought about concussion or brain injury as requiring loss of consciousness, and that's obviously not the case. In fact, less than 10% of concussions will have loss of consciousness. But there should be a mechanism of injury, either direct to the head or violent enough to the body to cause a rotation and a whiplash effect. While the majority of folks will get better by 2 weeks and probably over 90% recover by 4 weeks, I think it's still useful to think about the mechanism and the location. So traumatic brain injury, I think, fits pretty well. Temporary brain injury, I think, is reasonable, but still that's the accepted moniker we've given it so far.
I will bow to you on that one, Michael. But the word concussion itself, does it actually describe this injury adequately? I feel it's a soft word for what in fact is an injury to the brain, because in simple terms, the brain is us. This is what we are. The brain is what actually commands us. Why don't we classify it as brain injury first degree, second degree, third degree? Why do we, why is it so complicated to get around the kind of severity of this injury?
Yeah, that's a great point. So some of that goes back a little bit to recent history. So you're right. Concussion sort of, we hear it so much now, perhaps it's lost some of its meaning or its impact. But one of the reasons we've moved away from grading systems is a few years ago, there was several grading systems, the Cantu grading systems, the American Academy of Neurology grading systems, but they were more focused about loss of consciousness or the number of concussions within that particular season. And so a grade 1 concussion was considered to be no loss of consciousness and symptoms that resolved within 15 or 20 minutes, and athletes back then were able to return to the contest the same day. Well, we learned that, number one, not every concussion is the same, and so diagnosing a grade 1 concussion and giving prescribed 1 week of rest then return doesn't work for all athletes. And so we changed our management to say, well, instead of grading these concussions from the beginning and saying they're grade 1, grade 2, grade 3, therefore you're out for 1 week or you're out for 1 month, instead of doing that, we said, okay, we're going to watch each individual's recovery, and we're going to diagnose the concussion and treat the concussion and determine the return to play only when they meet other criteria, independent of loss of consciousness or not. So that's why we moved away from the grading system. And so now we have a much more individualized approach where we're assessing really 4 different factors before we're considering return to play. And since that time of those grading systems, we've moved away and we've made a commitment to say, look, if we consider that this may be concussion, we made a commitment to say this athlete is not going to return to contest that particular day, in part because the symptoms evolve. And so if the symptoms are improved, or if the athlete is motivated and says, I have no symptoms at all, we still don't feel confident that there may not, there still may be a concussion, and that athlete may be still at risk, especially that particular day, and until those symptoms and that injury is resolved. So as I said, we would define now recovery as symptoms that have resolved, exercise that doesn't produce, so exercise tolerance, exercise at low, medium, and high intensity don't reproduce symptoms. Cognitive exertion, like school, for instance, doesn't produce symptoms and performance is good. And then number 4, some type of cognitive assessment. In professional sports, and for that matter, high school and college, you're often hearing about computerized testing, although we should note that that's not required to do effective concussion management to have computerized testing. But there should be some type of concussion or cognitive assessment once the athlete has resolved the symptoms, demonstrated cognitive exertion, and demonstrated tolerance to exercise as well. So that's a brief history about why we've moved away from the traditional grading systems that were originally in place. But you're right, at the moment, if we say, well, this is concussion, or this is your second lifetime concussion or third lifetime concussion, it really doesn't describe much of the severity of that person's individual experience, because one person may have very mild symptoms for 1 or 2 days, and that was their first lifetime concussion, and compared to somebody else who had 3 lifetime concussions, they had severe symptoms, they lost 6 months of school, they required prescription medications. Technically, both of those are concussions. However, there's the second athlete clearly has a much more impact to their life, and what we would consider a much more complex or difficult concussion. So there probably is some room for a further description or perhaps a grading system, but that's the reason for the moment we've moved away from grading system.
I think that was well explained, Michael, and very thorough. Thank you. Based on that, actually, would it be correct to assume the treatment program is different in relation to the child and young adult as compared to the adult population? Because a lot of those protocols literally don't make any kind of a dissimilarity between both populations.
Yeah, you can split or think about different populations in several different ways. You can think about age alone. So young athletes in grade school level, and for that matter, athletes in the college level don't seem to have as much of a difficult time as that middle age group, so the high school level. So there's the younger population and the older population seem to have less difficult time with concussions as far as prolonged recovery. Now, the overall approach is still generally the same for young and adolescents and older athletes. Again, if we recognize the concussion, we'll withdraw the athlete from competition that day, and we'll make a commitment to not return them until we see those same 4 criteria. For very young athletes, doing the cognitive assessment, even computerized testing, it's difficult to get a read sometimes on the very young population. For instance, let's say age 8 or 9 years old, we'll often use either verbal testing or computerized testing, but the testing that exists for the very young population is different for the older population, partly because their interaction with physicians or clinicians or coaches is different, and partly because their cognitive abilities are evolving rapidly. So if they have for instance, if they have a healthy baseline on this particular computerized test at age 8, at age 8.5 or age 9, their cognitive performance may be very different. They're evolving that rapidly. So the validity of that first baseline test may be expired very quickly, as opposed to a college age athlete over age 18 whose cognitive development is much more fixed and much less rapidly developing. That person's baseline performance on a concussion test is more likely to be representative if we do a post-injury test a year later after they had an injury, and we're trying to compare and how well they're doing for cognitive testing in that particular realm. But in general, and by the way, the other thing, the most difficult part I find for treatment of concussions is the school management. So the younger kids in grade school, actually, I find there's a bit more flexibility. There's less pressure, if you will, or they end up missing less volume, or they seem to have an easier time to make up missed work when they're in the grade school, as opposed to the high school level, especially the junior year or senior year, where the intensity is extremely high and the volume of work is extremely high. So a missed few days or a missed week, certainly 2 weeks of missed school, has enormous implications for that athlete trying to make up or keep up with workload throughout that semester. And lastly, I would say the injury itself may have different implications, again, just in cognitive development. So in younger athletes, there are different milestones that the student athletes are expected to meet. If the injury itself physiologically interrupts development, or if they miss school or they have a change along their pathway, it may have further reverberations down the pathway, as opposed to, again, the college athlete who's already made several of those milestones. They've had an opportunity to get fixed cognitive efforts, and they're further along down their development. We started by saying you could separate or categorize different groups of athletes. We started by saying, sure, you could break them down by age alone. There is some reason to believe, well, what about if we identify other reasons, other factors that might predispose to prolonged recovery? So prior concussion injury can be a risk factor for prolonged recovery. Certainly multiple collisions before the concussion is recognized is a risk factor for prolonged recovery. Pre-existing migraine and possibly pre-existing learning disabilities. These can be risk factors that may predict the potential for prolonged recovery in an athlete. And it's possible, it seems like perhaps gender, female athletes may have a propensity or it may be a soft risk factor for further or prolonged recovery, as opposed to male gender, when every other factor is kept the same. So the treatment plan in those athletes may be a little different. We may be more conservative. We may be more conservative for return to contact, but we would probably be more aggressive to keep an eye on them, keep a close eye, add more cognitive support or academic support during the school year. And we may also, we'll talk, I'm sure, in a few minutes about other interventions that we do, but for those athletes who are at risk for prolonged recovery, I would probably institute the other proactive interventions for concussion beyond just saying, well, let's rest. If they, for instance, if the patient has prolonged symptoms, particularly for headache, we may move into different modalities just to treat headache. At the same time, we're trying to keep them out of contact. But we can talk about interventions, I think, in a few minutes.
Pretty thorough, Michael. I think I can take from that if I take one more concussion at this stage of my career, I'm finished. But looking at the European level, I mean, the grade school, and just explain to the people here, would be actually our primary level, and the high school would be our secondary school level. So we're looking at kids at grade school probably up to 12 to 18, then in the secondary school level. You know, it's a difficult thing, and just, you know, we're looking at the new inventions, really. I mean, it's on the road for a long time. I mean, it's much more prevalent now. It's much more professional what we're looking at concussion. So what's new in the field of prevention in the US? We know that helmets have been tried, mouth guards have been tried. The research doesn't back them up. The latest buzzword seems to be the strengthening of the neck and associated trunk musculature. What's your opinion on the sameness? Where is the research showing us at the moment? There's no magic bullet. There can never be. What is it pre-season athletes can do that might lessen or decrease the effects of concussion?
Yeah. This part is the holy grail, if you will. So again, I mentioned I work at the McKaylee Center for Sports Injury Prevention, and that's one of our main goals, is not just to treat concussions, but to discover how can we prevent them in the first place. Of course, that would be the best medicine of all, right? And certainly in the U.S., there's been explosion of efforts to include technology to decrease concussion or decrease injuries and all other injuries in sports. And to this point, I think it's been somewhat disappointing. Now, the technology has centered around two things. Number one, identifying injuries on the sideline. So, for instance, there's more iPads or applications where they're measuring sway and balance measurements on the sideline to see if an athlete is demonstrating concussion or not. There are helmet sensors to sense the amount of impact that an athlete may have sustained. There are other visual and sideline memory apps that are being used. Again, these are really done in an effort to identify concussions, but to be honest, they're really doing nothing, of course, for prevention. The helmets, I think, over years have been better in design. In the laboratory, certain helmets have been able to demonstrate more absorption of force. There's some debate whether they're actually reducing concussions on the field. And so for the moment, there's no consensus to say, well, this is the best helmet or this mouthpiece will prevent concussion. So in that way, technology has been somewhat disappointing as a concussion preventer. And if you look at the rates of injuries, let's say, for instance, for soccer, frequently there's concussions with head-to-head or head-to-ground collisions when they're going for headers. So, and for that matter, it's been postulated that athletes with a bigger head-to-neck mass ratio, so for instance, if their head weight is different than their neck strength, then they may be at more of an opportunity for rotational acceleration or awkward falls hitting the ground, hitting another player's head when they go for the header. So we focus a bit more on the athlete themselves, working on upper back and neck strengthening and body control, what we call proprioception, in an effort to prevent the awkward falls, the awkward collisions, the unintended collisions, and ultimately that may help prevent concussions itself. So I think that's been part of our individual efforts for each athlete. The thing that I think probably works the best is coaching changes, rule changes, and practice changes. So, for instance, American football, traditionally, years ago, it was tradition in the beginning of the season, you just go hit and you start doing more tackling drills as soon as you can. And either it was an effort to, quote unquote, toughen the kids up or to weed out the athletes who didn't really want to be there and go through the hardest parts of the training camps. Well, I think we all can agree there's no way you're going to toughen up a brain or prevent concussion in that way. What you'll do is add more injuries and injuries among the team between themselves during practices. So there's been a big effort in changing practices to do less hitting at full speed, but more teaching of how to tackle and hit properly, which I think only makes sense. It'll only make for better football players. It'll only make for less missed tackles and ideally less injuries, especially among the squad themselves. And then enforcing rules, you'll see, for instance, in the NFL or other leagues, there's been new rules to prevent unnecessary hits or hits to, for instance, wide receivers that are unprotected or who are defenseless. I think the more that those are enforced, we'll see less unnecessary hits and hopefully better tackling in general, where it doesn't need to be one tackler coming in like a missile, just knocking the other guy as hard as he can, but just taking the athlete to the ground and doing a proper tackle. I think that really does help with less injuries across the board, including concussions.
Okay, well, a colleague of ours, Brian Fitzgerald, which I worked with many years ago, I know he's now a neutral observer for the NFL. They brought them in because they couldn't trust the team doctors, and I know myself being on the side, and it's very difficult dealing with concussion. Players want to play on, management want them in there. But Brian sits there when he sees something wrong, he gets into the referee's helmet and say, number 88, got a problem, he must be taken off. He's evaluated independently of the medics of the two teams, and therefore that's a stride forward as far as I'm concerned. I also know if I see a guy get a slight hamstring strain, that if I leave him on longer, that he's actually going to make that a lot worse. The same applies to concussion. If we take that initial hit and we leave a player on longer, he's obviously, even if he's not hit a second time, because of the movement, he's going to be a lot longer recovering after, because of the fact he has actually continued to play. So these are very valid points. Let's just go to baseline testing, which you talked about before there. We did in Harvard the 18th with varying results, not obviously as sophisticated as it was now. I was in AT there, we did 3 field tests. Our field tests we were doing was just pen light looking for constriction dilation. We looked at the 100-7 maths test, which I thought was kind of a little bit kind of ironic, considering these are Harvard students. If they can't do 100-7 minus 7, I don't know why they're in Harvard. That's beside the point. And we did the balance test for VOMs, as we know, the ocular stuff, and basic eye test. And that's all we actually had in those days. It's a much bigger armament that we have now to test, and yet it is still not definitive. It is still very, very difficult. What do you feel are the advantages, disadvantages of modern day baseline testing for athletes?
Yeah, well, excuse me. The advantage would be to have something objective and reproducible. So we want any test to be accurate for what it proposes that it's going to test and reproducible. So the current tests that are out there, we use some of the computerized testing, and I like it because it's objective and it's reproducible and it's transmittable. So it's something that we can talk to the athlete, the parents, the coaches about as a data point. Beyond that, we have subjective testing. So we have symptom reporting, and that's sometimes very difficult. It's difficult for an athlete to reproduce symptoms or to describe symptoms sometimes at the beginning of the season versus the end of the season when the pressure on that athlete is to return. And every athlete's different. They'll describe subjective symptoms differently. So objective data, I think, is useful. The computerized testing that we use, I find it helpful to have pre-injury or baseline testing typically before the season is started. But it's not absolutely necessary. So I think the idea of doing that is useful across the board. But we're going to have visitors here in just 1 second here.
I think I could pick up on that, Michael. Hello, guys. But let's carry on.
Yeah, bear with me 1 second here. So I think it's useful to do that before the season. But for sideline management, I don't think it's very helpful because you can't really have them sit down and do a computerized testing for their rapid assessment. So those computerized tests take about 20 or 25 minutes to do.
Okay, Michael. We'll move on quickly before we get the whole circus here, but not to worry. Last question I throw at you. Before I let you return to your duties, sport has to look at rule changes. We mentioned that before. Soccer took the elbow out and actually concussions has closed down since the soccer elbow has been taken out of it. Typical concussions. Is there research in the US at the moment in relation to the ratio of concussion in game versus practice? Is a breakdown anywhere there shows where the concussions are coming from?
Yeah, there's a couple of good studies that came out fairly recently. Don Comstock was one of the authors on a few of them, and this confirmed what's the work that's been done in the past. It does look like consistently gameplay has higher rates of concussion than practices, and that may be for different reasons, whether it's intensity or other factors. That's not exactly clear, but consistently across several sports that were identified, including American football, soccer, even wrestling, I would say it's consistent that gameplay and competition has higher rates of concussion than practice.
Okay. And I'm going to sign off in a second, Michael. Thanks a lot. I see you some visitors coming in there. And I do know, Michael, you've given out an excellent video. It's on Open Pediatrics, is that correct? And
that's right, yeah. Open Pediatrics is a free-to-view platform that's just aimed at teaching clinicians and trainers and coaches, as well as parents. So we did a section on that for concussion, which I think does a pretty good job to go over the concussion management and the principles of current thinking in concussion. So if you Google search Open Pediatrics and concussion, you can see this video. I reference some of the exercise and academic progression sheets. So those are free for download on Open Pediatrics, or they're on our website at Boston Children's Hospital at the Concussion Clinic. But I think it's useful, and I try to answer most of the common questions for concussion management in that video.
Yeah, I've looked at that actually, Michael. It's an excellent video, and I'd recommend everybody do it. And there's also two other things I'd like to draw people on Google again. You can get the Berlin Concussion Statement from 2016, which is very helpful on the updated modern approach to concussions, and also the SAT-5, which is the Sports Concussion Assessment Test 5, most updated one as well. They're all downloadable. I think it's very, very helpful for anyone that's out there in the field to learn. It is the hardest thing we deal with is concussion. It's easy with blood. Concussion is extremely difficult, and you have to remove, even if in doubt, sit them out is still the mantra, I think. Michael, it's been brilliant talking to you as per usual. I'll see you in the new year. We'll sit back down somewhere in Galway and we'll discuss concussion, no doubt, again. Michael, beautiful. Over from Galway. Thanks, my good man.
James, thanks so much for having me.
Thank you.